The Farmer and His Sons. A rich old farmer, who felt that he had not many more days to live, called his sons to his bedside. "My sons," he said, "heed what I have to say to you. Do not on any account part with the estate that has belonged to our family for so many generations. Somewhere on it is hidden a rich treasure. I do not know the exact spot, but it is there, and you will surely find it. Spare no energy and leave no spot unturned in your search." The father died, and no sooner was he in the grave that his sons set to work, digging with all of their might, turning up every foot of ground with their spades and going over the whole farm 2 or 3 times. No hidden gold did they find, but at harvest time, when they had settled their accounts and had pocketed a rich profit far greater than any of that of their neighbors, they understood that the treasure their father had told them about was the wealth of a bountiful crop, and that in their hard work they had found the treasure. The moral? Hard work is itself a treasure.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Patients come to us all of the time with what can be a confusing mixture of acute and chronic symptoms, and sometimes we fool ourselves. Probably out of convenience or just survival. That it's been going on for X amount of time, so it can't be an emergency, or it can't be that important. Sound familiar? We're all guilty of this. Musculoskeletal complaints sometimes fall into this category, and we're more likely to call it chronic or not emergent or maybe not that important if, we don't really know what it is. Today, I'd like to challenge us, you and me, to tackle the complaint of knee pain by really digging into the history, really cultivating our physical exam. The extra time you take to do a great history and physical examination may reap benefits and save a treasure trove of repeat visits and frustration. Today, we'll go through pearls in the H&P to help us with our differential diagnosis, which is considerable. Now, of course, you're going to be able to diagnose the septic joint pretty clearly. Pain, irritable joint, maybe fever. I'm not talking about that kind of knee pain, or even the referred pain that is classic for hip pathology, or maybe a skiffy. We're also not talking about major trauma. With a thorough evaluation, you're not going to miss anything. What we will talk about today will be heavily sports medicine based. Now, it is true that with a lot of these conditions, the kid's going to live regardless, and you may shrug your shoulders, give an NSAID, immobilize, and see the next patient. But that to me feels a little bit like giving up. You can make a big difference in the child and family's lives if you take a moment to consider what is really ailing them. The follow-up, the treatment, the precautionary advice really end up being very different depending on the etiology. And there's another thing that is forgotten often. Our own job satisfaction. I want us to look forward to these patients. We can really help them. They are often in real pain and very frustrated. Having a few more quivers in your diagnostic arrow bag can really help us to target that knee. So, let's go over apophyseal injuries, patellar tendonitis, anterior knee pain, meniscal injuries, ligamentous injuries, and articular cartilage injuries. A lot to unpack, so here we go. Before we get into the nitty-gritty of the knee, a brief review of the relevant anatomy. Your knee is the largest joint in the body. It's a workhorse, powerful, but that also means it's always at risk for some injury. The femur ends at its lateral and medial condyles, which articulate with the tibial plateau. Anteriorly, you have your patella ensheathed in the patellar tendon. Bony structures? Check. Other than major trauma, it's the soft tissue structures that cause the most pain and the most annoyance. The anterior cruciate ligament, the ACL, it originates in the, well, you guessed it, the anterior tibia and inserts into the lateral condyle of the femur. The posterior cruciate ligament, the PCL, originates in the posterior tibia and inserts into the medial condyle of the femur. Together, these cruciate ligaments, these cross-like ligaments, stabilize the joint anterior-posteriorly. The medial and lateral collateral ligaments insert where you think they would and provide sideways stability. The medial and lateral menisci serve as shock absorbers for this massive joint, and they both interdigitate into the ACL and the PCL for more stability. Okay, easy peasy. Now it gets interesting. To improve the shock absorbance, there are multiple bursae in and around the knee joint. The suprapatellar bursa, infrapatellar bursa, prepatellar bursa, and the pes anserine bursa. They're all where you would expect them to be. Recall that the pes anserinus is the medial triple conjoined tendon where the semitendinosus, gracilis, and sartorius muscles end. The pes anserinus splays out over the medial aspect of the knee and looks like a duck foot, pes anserinus. So the pes anserine bursa is the shock absorber tucked into that tendon medially. Other problematic structures include the quadriceps tendon inserting into the patella, the patellar tendon inserting into the tibial tuberosity, as well as the iliotibial band, a fibrous support of the fascia lata originating at the external lip of the iliac crest and inserting at the lateral condyle of the tibia at a site called Gerdy's tubercle. Any of these soft tissue structures can act up and cause trouble. So let's get to it. On history, was this traumatic or atraumatic? Can the patient bear weight? What was the timing of symptoms? Is the pain worse in the morning or after prolonged use? Was it sudden or has this been going on for some time? The pain location, really try to get them to specify. Have them show with one finger where the pain is worse. Now, this is tough because often you're met with an open hand and a very large circular motion that seems to include the whole joint. Work from least painful to most and try to localize as much as possible. Is there any swelling? Was there any catching, locking, or giving way? People say a lot of things like, I heard a pop, or my leg gave out, and you may be thinking, what am I going to do with this? It turns out that these things actually can help us to narrow down what type of injury occurred. Okay, this isn't perfect, but here's a list. Rapid fire. I heard a pop with non-contact injury, likely an ACL tear. I heard a pop with contact injury. Usually that's going to be a collateral ligament or meniscus tear. My knee gave out, likely an ACL tear. I fell on my flexed knee, PCL tear. And then a lateral blow to the knee is a medial collateral ligament tear, and a medial blow to the knee is a lateral collateral ligament tear. You're just stressing the opposite side. If there's acute swelling to the knee, and I mean pretty immediate, then really all of these are possible. ACL, PCL, fracture, or even dislocation. Always keep in mind hemarthrosis and potential tibial plateau fracture. Now we're talking aspiration for blood and maybe fat globules from the marrow or CT rather than just plain films. Physical exam. On inspection, look for alignment and swelling. Lying supine with the knee extended, have the patient activate the quadriceps. There should be a dimple on each side of the patella. No dimple? Then there's an effusion. Test for range of motion. How far can the patient flex and extend? Have him push back the knee onto the gurney to give you a sense of how far he can extend the knee. Have him then flex his knee and bring it back as far as he can so that his heel is as close to the buttocks as possible. Can't do active range of motion? Try gentle passive range of motion. Next, move on to the patella. Have the patient tighten the knee and palpate the quadriceps tendon at the superior pole. Is there evidence of tendonitis there and just there? Have your patient do then a straight leg raise to test for quadriceps strength and integrity. Now, palpate the body of the patella for tenderness. In an adolescent, if there's tenderness at the inferior pole of the patella, well, you've got on your hands Sinding-Larsen-Johansson syndrome, an apophysitis of the patella. Follow down to the patellar tendon and its insertion in the tibial tuberosity. Tenderness to the tibial tuberosity in an adolescent? You got this one. Osgood-Schlatter syndrome, an apophysitis of the tibial tuberosity. Then move on to the sides of the patella. On the medial side, the patella is stabilized by the medial retinaculum, which attaches to the medial femur for stability. Tenderness on the medial aspect may show a medial plica band. It feels like a thickened bowstring. A plica is a fetal remnant. It's an abnormal extension of the synovial capsule that can become irritated and inflamed. Staying medially about the knee, look to the medial proximal tibial surface and palpate the pes anserine bursa. Pain, swelling, or tenderness there may be bursitis. Then feel under the patella as far as your fingers will go for tenderness on the articular surface, which could indicate Patellofemoral Syndrome. If you are careful, you're calm, and you're gentle, going from light to deep pressure slowly, it won't hurt unless there's some pathology. Try to keep that knee relaxed. The quadriceps really have to be disengaged. Start low and go slow. If you jab in, of course, you're going to elicit some pain there. Now, let's go lateral. To assess for patellar instability, have the patient supine with the knee flexed at 30 degrees. Again, the quadriceps have to be really relaxed for this, so you can place a towel roll under the knee. Slowly pull the patella towards you laterally. If the patient feels apprehension or grimaces or gets anxious, this is sensitive for patellar laxity and potentially a previous patellar dislocation. Now, bend the knee and palpate the joint line carefully and slowly. You're trying to localize whenever possible. Tenderness may mean a meniscal tear. If your patient has, say, a generous body habitus and finding the joint line is tough, it turns out we're all pretty fit around the fibula. Find the head of the fibula laterally and then trace the joint line back that way. With the knee still flexed, palpate the hamstring muscles. Laterally, you'll feel the biceps femoris. Medially, the semitendinosus and the semimembranosus. Some people are chronically tight because of poor training or just not enough stretching. If you find this, it's a pretty easy cause of their knee pain that no one had just bothered to look for. Clark's sign can be found in Patellofemoral Syndrome. The patient is still supine and the knee is extended. Grasp the superior pole of the patella with your thumb and index finger and have the patient fire the quadriceps, tightening the knee while you resist the patellar excursion. This causes a grinding of the articular surface between the patella and the femur. Pain is indicative of Patellofemoral Syndrome. To perform Patellar Allotment, with the palm of your hand, sweep down the distal anterior femur, ending by cupping the superior pole of the patella with the web space between your thumb and index finger. Keep that hand there while you use the other hand to palpate around the knee for fluid. You're sort of milking that knee. You can also see if the patella is floating in excess fluid by pressing down with your thumb and releasing quickly. Fluid under pressure bounces back. You didn't think the patella was that interesting, did you? Now, let's test the cruciate ligaments. The anterior drawer test evaluates the integrity of the anterior cruciate ligament. Flex the knee to 90 degrees and translate the tibia anteriorly with directed force. Another test is the Lockman Test. It's the most sensitive for an ACL rupture. Use your non-dominant hand to cup and support the back of the knee. You have to get them to relax the quadriceps and hip flexors for this to work. Grasp the proximal tibia with your dominant hand. Flex the knee at 20 to 30 degrees and pull sharply in the proximal tibia anteriorly. It's a directed force. The tibia shouldn't move much and you should feel a distinct endpoint. If you feel a softer endpoint or you have more translation than on the other side, you likely have an ACL tear. The posterior drawer test is for posterior cruciate ligament integrity. It's a mirror of the anterior drawer test. Flex the knee again to 90 degrees, but this time, sit on the patient's foot. If you can, try to get a little more leverage that way, and grasp the proximal tibia with both hands so that your thumbs are on either side of the tibial tuberosity and your fingers wrap around the calf. Push back abruptly to translate the tibia posteriorly. It shouldn't move more than a few millimeters. The Posterior Sag Test also tests for PCL injury. Have the patient supine, hip flexed at 45 degrees and the knee at 90 degrees. Look at the knee from the lateral position. If the PCL is damaged, you'll see the tibia is sagging posteriorly. To test the collateral ligaments, perform Varus and Valgus stresses. Valgus means knock-kneed. A valgus stress is for medial collateral ligament integrity. We're first going to test at 0 degrees of knee flexion because that's the most sensitive. Abduct the hip slightly and keep the knee straight. Cup one hand under the knee to support it and stabilize it, and the other around the ankle. Now, just think about what you want to accomplish here. We're trying to stretch the medial collateral ligament. You're making the knee into an inward V, a valgus stress. If there's laxity, this means that the medial collateral ligament has some damage, and at 0 degrees, this means there could possibly be some cruciate ligament involvement as well. This, again, is the more sensitive way to do it. If you have pain there, then you should move on further to try to isolate the medial collateral ligament. So then you can bring the knee slightly over the edge of the table and then flex it at 20 to 30 degrees. You'll repeat the stress, now trying to isolate the medial collateral ligament. Again, try to get the patient to relax, and you can let the rest of the heel fall on the gurney itself. This will deactivate whatever stability the cruciate may provide and, again, isolate the medial collateral ligament. Repeat that test and apply valgus force for any type of instability. The Varus test is the same procedure, but you're just doing the opposite movements so that you're trying to stress the lateral collateral ligament. Comparable size for laxity if you need to. To evaluate the menisci, use the Macmurray Test and Apley's compression test. For Macmurray's, have the patient supine, hip and knee both flexed to 90 degrees. Take your non-dominant hand and place it over the joint line of the knee. Your dominant hand will now grasp the patient's heel, and you can internally and externally rotate the tibia, exerting valgus or varus forces while extending the leg. This will help to grind on either the medial or lateral menisci, and you can control which one you try to evaluate for with each grind. Again, grinding over and extending the leg at that time is the most sensitive. Pain, popping, or clicking is a positive test. Apley's compression test also tests for meniscal tears. In this case, though, you're going to use gravity to be on your side. Have the patient prone now with the knee flexed at 90 degrees. You're going to compress the leg into the gurney and rotate from side to side. Pain or a popping sensation means that meniscus is damaged. Well, that all sounds cut and dry, doesn't it? It's so obvious, or so you're told later on when there's a visit to the orthopedist's office 1 to 2 weeks later. Sure, it's more obvious now that the pain, the swelling, and all the fear have subsided a bit. My point here is that the exam, no matter how masterfully done, is just limited in the ED because of the acuity of the injury. It can be very challenging to do a proper knee exam in the acute setting. Let me paint a picture. Children and adolescents will not want you messing with their knee. Wait, let me rephrase. No one will want you messing with their knee if it's just been hurt. If there's a big effusion, you're not going to get a precise exam. We're only really looking for major red flags on the H&P at that point. These are an inability to do a straight leg raise. If you find ligamentous laxity, bad. If there's any catching, locking, or giving way on exam, also a red flag. And of course, the inability to fully straighten the knee. Now, on to x-rays. Okay, you may say, not everybody needs an x-ray. To that, I'll say that skeletally immature bones can fool you. The radiation is minimal and the yield can be high. Diagnostically, or at least in terms of a better night's sleep for everyone. MRI is expensive and it's often not needed in the acute setting. It would also grind the ED to a stop if we use that precious resource for a non-urgent indication. Plain films are still the diagnostic imaging modality of choice. Okay, let's get into specific conditions. Let's start with the less scary injuries, the apophyseal injuries. Apophyses are not born, they're made. These secondary ossification centers are where tendons insert. During the child's normal growth spurt, the bones will grow faster than the muscles, causing pain, often in the form of shin splints. On the knee, you may see some pain and swelling. Osgood-Schlatter disease is an apophysitis of the tibial tubercle, one of those pesky apophyses. Another one we also mentioned is Zinding-Larsen-Johansson syndrome, an apophysitis of the distal patella. Film them to verify there's no concomitant injury, and then it's the good old RICE. Rest, ice, compression with the knee strap, correction of any training errors, and anti-inflammatories. Patellar tendonitis is also called jumper's knee. It's caused by overuse and overstrain. You'll see pain and swelling just above the tibial tuberosity and the patellar tendon itself. Treatment is, you guessed it, rest, ice, compression with a knee strap, NSAIDs. Patients who come in with subacute knee pain are the real Pandora's box of the knee. Patellofemoral Syndrome, also called runner's knee, is not uncommon in cyclists, basketball players, and of course runners. You'll get the story of pain with running or going upstairs. The theater sign, or the movie sign, is the history you'll get when the patient has pain with prolonged knees that are flexed, when they sit for long periods of time without getting up. You might feel crepitus with range of motion. Runner's knee is treated the same as we've talked about, but people with this condition will often benefit from physical therapy and focused strengthening of the muscles around the knee joint. Meniscal injuries are very common and can be traumatic or atraumatic. Try to really hone in on the history here. In adults, this is just from wear and tear. In children, there's often some specific incident. They may report increasing pain with activity or catching or locking of the knee. You may see minor swelling, maybe some joint line tenderness to palpation, or they could have a positive Macmurray sign or a positive Apley sign. The treatment here for meniscal injuries is a little bit rough. Physical therapy will strengthen the muscles around the joint, and they may compensate for the tear, but of course, that's not going to heal the injury. Surgery is not for everyone, and it's mostly reserved for those with mechanical symptoms that stop them from safely performing ADLs. Ligamentous injuries are equally rough. We talked about how an ACL tear can be from contact or non-contact. It causes swelling, stiffness, and pain. Chronically, it can feel like the knee will give or buckle. You'll see a positive Lockman sign and a positive anterior drawer sign with an effusion. The ACL is really bad at self-healing, and if it's a significant injury, graft surgery is the way to go, but recovery from that can take 6 to 8 months. PCL injuries rarely occur spontaneously, and they rarely occur in isolation. They usually happen with contact injury and with multi-ligament injuries. You'll see pain, swelling, and likely find a positive drawer test or a positive tibial lag. The good news is that your PCL is actually much better at healing itself than the ACL is. So low-grade PCL tears are usually non-operative, and grade 3 and higher PCL tears need reconstruction. Collateral ligament injuries can also be due to contact or non-contact. There isn't much swelling with them, but you do see significant pain, especially on valgus and varus stressing. Collateral ligament injuries also have good healing potential. So the rest, the ice, the bracing, and slow advancement of range of motion is the way to go. Articular cartilage injuries can be tricky. They may have many of the same symptoms as the meniscal injuries have, but to be honest, I've seen these mostly diagnosed by MRI or on arthroscopy. This isn't really something that we would take care of in the ED, but in case your young athlete will ask you, if it's non-operative, it's going to be rest, ice, compression, and physical therapy. Operative repair may include microfracture, where the surgeon causes a small fracture, or chondroplasty, a direct repair of the cartilage. Both of them work by stimulating fibroblast growth that will fill in the fracture line as well as the articular cartilage defect. It's not perfect. The knee will never have that smooth articular surface again, but they're both feasible. Another option is the Oates procedure, or osteochondral allograft transplantation surgery, which uses cartilage from a donor. Gudis et al. In the journal Arthroscopy found that 93% of patients who had the Oates procedure were able to return to their pre-injury level of sports versus 52% who underwent microfracture. Mostly treatment of what we call internal derangement of the knee involves non-weight bearing and a knee immobilizer until the child is evaluated again in 1 to 2 weeks. MRI is typically not indicated in stable joints because the edema can obscure the tear, It's also very resource intensive and not needed. That information is not going to change what you do for this patient today. I tell families demanding an MRI for a stable joint that the swelling may fake us out. It can push tissues together, making the injury seem less than what it really is. We need time to reduce the swelling, and MRI is always there if you really do need it later. Unstable joints, so high energy trauma with laxity, that deserves a thorough vascular examination, possibly angiography, a talk with an orthopedist, and if all ends up being fine, then close follow-up. Now, of course, there are many, many more things on the differential diagnosis, but as long as you don't think it's infected, you don't think the knee pain is a fake out from the hip, and the knee is mostly stable, there isn't any concern for previous knee dislocation and subsequent popliteal vascular injury. If all of these things are okay, then we have time to evaluate, to treat, and to follow up. Another non-urgent but pressing diagnosis is Osteochondritis Dissecans. It's a condition which you have a small portion of the articulating surface of the bone and cartilage. They undergo repeated stress and they slowly separate from their blood supply. Now, this can happen in the ankle, in the knee, or even in the elbow. Symptoms are just chronic pain and swelling of the joint. X-rays may be suggestive. Treatment is almost always initially supportive. It's just good to know about osteochondritis dissecans because we never want to say your x-rays are normal, you're fine, you don't need more of a workup or follow-up. This diagnosis may elude us initially. The power in all of this knowledge and everything that we've talked about today is that you can help to adjust the patient's and the family's expectations and put them in a more realistic frame of mind. It'll help them to go through what is likely going to be a tough couple of weeks or months, especially for someone who's been so active until just now, until the injury, whether it's acute or subacute. Now, after your good history, your good physical exam, and even some films, we may just know in the end that there is some internal derangement of the knee acutely. It's a generic term for just some soft tissue condition, often accompanied by swelling. Just make sure that you explain the definition to the parents if this comes up. And lastly, think about the new diagnosis of a malignancy around the knee, like a sarcoma. This is just another reason why x-rays for just about everyone is not a bad idea. So, instead of blowing off the patient with knee pain, remember that hard work in itself is a reward, and it just might reap the harvest of a solid diagnosis and plan, or at least sow the right seeds. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.